physician from Costa Rica who is currently undergoing an observership here at this great center, Hennepin Healthcare. And today I presented this case in the morning report, and I would like to share it with you. Don't hesitate on pausing the video so you can answer the questions and participate actively throughout this patient presentation. So the year is 1958. We are located in Boston, and we have a 13-year-old child that has several bouts of fainting, and this child has just fainted or lost consciousness and hasn't recovered consciousness in several minutes. That's why the patient has been rushed to the hospital and you are receiving the patient. So what we are seeing here is an excerpt from the article I took this case from, which is showing us the history of present illness. So try skimming through this excerpt and let me know which words repeat or stand out for you. What is remarkable about it? So pause the video, see which words repeat or which words are interesting. Okay, so very well done. So you probably noticed the word fainting, unconscious twice, also crying, and deaf and mute. Okay, so we know this patient, in summary, has had several bouts which have been associated with crying or feeling stressed out. Bouts of what? Bouts of losing consciousness. So we know that correlation does not necessarily imply causality, but it's an important clue. And if we complement this, we can see that the morning spells seem to be prevented if the principal walked to the classroom or to the schoolroom with him. So we know the crying might have triggered this, and we know of something that might have been preventing fainting or loss of consciousness. This is interesting because what would it mean that the principal walks right beside a student to the classroom? It usually looks like a shield for the student. So if you're a little boy walking through the hallway, you know that there are many stimuli that might stress you out, might make you fearful, might make you want to cry. And having the principal right next to you, you're with an avenger, you're with this shield against any danger. So that's interesting. So something emotional might be going on, leading to this loss of consciousness or alleged loss of consciousness. So what happened? Okay, let's see. Before that, the physical examination. So I'm just gonna say that the only finding is mild cognitive limitation secondary to speech and hearing impairment. Nothing else is special of the history of the physical exam. The rest is totally normal. And we already know that the patient has congenital deafness and mutism. So we also have lab work and imaging, so pause the video to think about which labs you would like to ask for and which imaging techniques you would also like to complement your assessment with. So I would like to state that all the lab work that was done ended up normal, in the normal ranges, and we are in the 60s or early 60s, late 1950s, so we don't have very complex imaging techniques in that era and that moment in time. So the x-rays were generally normal. So what do you think happened to this British officer? Well, yeah, he lost consciousness. Okay, but which differentials come to mind? So when you're thinking about loss of consciousness, what are you thinking about? think in general, be it a child or be it a young adult. What differentials come to mind? Okay, very well. So one possibility would be neurologic, another possibility would be cardiac. The cardiac possibility can be divided into structural or electrical, right? Arrhythmogenic. And you also have the option of something that might appear as neurologic but maybe isn't neurologic in nature, but could be a pseudo seizure. So let's see how this patient was worked up and treated. Patient was diagnosed with epilepsy because his occipital lobes showed increased activity in his EEG, although there was the suspicion for this wasn't strong. The patient was diagnosed based on this finding and was started on diphenylhydrogen and towing twice a day. But after being started on the medication and being compliant with it, the patient fainted again. So the diagnosis wasn't too strong to start off with. And what happened? Okay, so they thought and wrote out in the file that the general impression in the hospital was that the attacks of syncope were hysterical, since physical examination was always negative both during and between spells. So now we know that this word isn't part of our medical language anymore. Now we know that it has nothing to do with any psychiatric diagnosis, and hysteria should no longer be a diagnosis we use, since it is usually violating women's rights. So there's a term for symptoms that are unexplained by scientific methodology, but the patient actually has symptoms, and these are called somatic symptom disorders. So this is the umbrella term that is the correct name for it in the DSM-5, and this umbrella term has different sub-diagnoses, which could all explain a sort of pseudo conversion or pseudo seizure. Okay, so the patient was diagnosed with something along this line, and what happened? So probably it wasn't somatic symptom disorder because the patient died. So this patient was unresponsive and did not recover from this loss of consciousness, and we didn't have a diagnosis. We were late 50s, early 1960s, and what we can see as the first authors of this paper are these two gentlemen. So does this ring a bell? Do these last names, Jervell and Lange Nielsen, make you recall something? Probably those of you that like the medical factoids or medical history or eponyms, right? So probably it might ring a bell, might not. And we have that the patient had a long QT. So this is the way medicine expands, and this is how we discover new illnesses. First, there's a case. No one suspects anything strange. Maybe there's some interesting characteristics. Patient is deaf and mute since birth. Patient suddenly dies. Okay, didn't find a cause. That was strange. But these two gentlemen, Jervell and Lange Nielsen, remembered they had seen a family that had 4 members that also had deafness and ended up having a sudden cardiac arrest or syncope. So due to those events, they went back and got the information for this patient, and this became, instead of one case, it became a case series into trying to find out what they shared in common, what their syndromic diagnosis was, and all these patients also had strange QT intervals or strange T waves. So this ends up being a new diagnosis that we now know of for many decades, which is long QT syndrome or the congenital subtype. So, why did this patient die? We already know the patient had a long QT. Why? What was the cause of death? Because long QT doesn't mean anything special till it manifests and converts into something. So many of us are walking around the street with a long QT. Many of us won't ever know we had a long QT if we don't get an EKG and don't have manifestations. But what manifestation may be fatal? Okay, so yes, very good. It's torsades de pointe. I guess it's pronounced like that in French. If not, please correct me. But what is torsades de pointe? Torsades de pointe is a form of polymorphic ventricular tachycardia. Not all polymorphic ventricular tachycardias are torsades de pointe, but all torsades de pointe are polymorphic ventricular tachycardias. There's other names for this also. So we can also call this helicoidal tachycardia, helicoidal ventricular tachycardia. That's another option. Why? Because it looks like a helix. So torsades de pointe means like it's rotating, and pointe means point. So you can see the EKG, it goes first with the positive vectors, then the vector goes negatively, then it goes positively. That's what torsades de pointe looks like. It's pretty characteristic. And this usually is related with no pulse whatsoever. So the patient that is in this rhythm has no pulse, isn't breathing. So we have to work fast. This is a code. We have to do what we have to do in basic CPR or advanced CPR. So this usually ends up, if we don't work effectively fast, this will degenerate into ventricular fibrillation. We know first it's coarse ventricular fibrillation, then it becomes a fine ventricular fibrillation. The more time that passes without being able to bring this patient back into spontaneous cardiac rhythm, the worse the prognosis. So we are guessing this patient had one of these events. And this patient fainted over and over again, probably during episodes of these non-sustained bouts of arrhythmias. And then when the patient came back into his senses, he would be evaluated and everything was normal because the patient had a normal physical exam, but he always had a strange EKG that no one knew how to interpret until the case series led us into knowing long QT syndrome is devastating if we don't do anything and act appropriately. So here we have Jervell and Lange Nielsen. In 1957, they gathered all the information for this patient, and that's how we now know of this disease. So this is known as the autosomal recessive long QT syndrome. Then came Romano and Ward. So Romano and Ward also described the same phenomena, but in this case there was a different pathophysiology, a different channel involved, and this was autosomal dominant. So my aid for Romano Ward for the boards or the USMLEs, because it's not that useful when actually seeing patients nowadays, because medicine has advanced. So now we have different phenotypes, phenotype 1, 2, 3, and it's not white or black, saying that it's dominant or it's recessive. No, there's hundreds of different mutations that can be occurring, but there's like 5 main mutations. So if you want a mnemonic that might help you to learn factoids or have it fresh for any USMLE exam or board exam, we have that the dominant Roman hears torsades. So autosomal dominant Romano ward hears because they're not deaf and produces torsades. How do you remember Jervell and Lange Nielsen? Just remember that they would be the opposite from this. So they would be recessive, they would be deaf, and also produces torsades. So here we can see what triggered the patient's syncopes and loss of consciousness. So what triggered it was the emotional stress. Here we have stress in each of the different phenotypes. As you can see, you have phenotype 1, 2, and 3. In the past, it was thought that each phenotype was produced by different triggers. But look at all of them. You can see that sleep is involved in all of them. Exercise is involved in all of them. So this is an illness where any patient that doesn't want to exercise can go on the web and can look up what are possible negative consequences of working out. And they can say, hey, but those people with long QT syndrome die because they're working out. So that's one of those moments you will have to say, yeah, so exercise isn't a good idea there. So if you have a patient with long QT syndrome, yeah, you can prescribe not exercising. But for most of the 99% of the population, exercise will be positive. So moving on, we're talking about a little more about the QT interval. Why are we talking about the QT interval? Well, we're talking about it because most physicians do not, well, most physicians are able to recognize what the QT interval is. So we have that 61% recognize the QT interval, but there's 39% of physicians or healthcare practitioners that don't even identify the QT interval. So first of all, we have to identify it. Second of all, we have to measure it correctly. And even more worrisome is that only 36% of the healthcare practitioners can actually measure the QT. And that is why we're gonna start off detecting and measuring it. So what I want to show you here is that in this COVID pandemic, when we were thinking of possibly using hydroxychloroquine, we started to we highlighted the importance of doing the EKGs to these patients because the hydroxychloroquine could prolong the QT, and it is important to know how the QT of these patients was. So the most prestigious society or American Society of Electrophysiology gave this statement in their own web page and had a link to how to measure correctly the QT interval. What was interesting is that in this same statement, the link they are showing measures the QT interval in a general way, generally correctly, but there is one of the last cases they show where they show a challenging QT where I actually proved it wrong. I wrote to them and I haven't received a response yet. I'm still waiting for a response. But what I want to demonstrate is that even the best of us can fail. So do not be afraid to fail. You have to practice and practice again till you get it correct. So this is the QT. Concentrate in the yellow, in this yellow section, and also try to correlate that with what is happening in the electrocardiogram. So what you could see is that the QT interval includes the QRS and the T wave. So basically, it includes everything that is happening in the ventricle. It includes first the depolarization, and after that, the repolarization of the ventricle. So there is a lot of things going on, and anything that is affecting those two physiologic phenomena can also change the course of the action potential duration. So anything that is affecting these channels, which would be calcium, potassium, magnesium, or sodium, can prolong the QT. So what is interesting here is that you have to remember that a valvulopathy isn't the same as a channelopathy. You can see a valvulopathy in echo. You cannot see a channelopathy with an echo. So don't rest, don't get too comfortable if you have a patient which has syncopes and his physical is normal, his echo is normal, he has a cardiac CT which is normal. Remember that this patient might be doing arrhythmias while you're not watching. So be sure to know how the QT looks. Has the QT changed? Have you already compared the different electrocardiograms? Because this might be the culprit. So let's just try to recall some other causes for QT prolongation. So just pause the video for a second and think of 5 causes for QT prolongation. And of these 5 causes, 2 are the most important ones. We already mentioned one, and that the one I mentioned, the most important one, epidemiologically, isn't congenital QT syndrome. It is actually medications and drugs. This one is one of the most important one, and the other second most important, or at least tied, is electrolytic disturbances. Why am I mentioning that they're the most important ones? Because this is what we'll see in the hospital. This is what we'll see in the critical patient, or any patient that has, or most of the patient that eventually have torsades in actual practice. So the congenital long QT syndrome won't be very frequent. It would be around 1 in 5,000, 1 in 6,000 persons in the United States have congenital long QT syndrome, and not all of them will manifest as such. So many will be walking around their daily living without ever having any manifestations. Some of them will, but the most cost-effective practice will be to have a high index of suspicion when we have patients on many medications and patients that have electrolytic disturbances. So these are reversible causes you can treat. So if you're wondering which are the medications that can prolong the QT syndrome, and you can recite them all, well, very good for you, because there are 190. You can see that there's more than 190 medicines as of today that can prolong the QT syndrome. Probably it's not a good idea to use our brain space remembering all these 190 medications. So let's use our smartphones, and let's use this web page that is recommended by the different societies in order to check on which medications prolong the QT. If you don't have this list, you can always go look it up in your trusted internet sites, of course, or I'll show you a mnemonic to remember the major groups of them. So here we have some medications. Look at these medications and supplements, and please tell me, what do all of these have in common? So pause the video, think of what do all of these have in common, and the answer is what you were thinking. So they inhibit the cytochrome P450 in the liver. What does this mean? It means the liver is metabolizing other drugs. Many drugs, or most drugs, are metabolized in the liver. If you inhibit this enzyme, you are increasing the half-life for many of these medications. And in these medications, you might have potentially prolonging QT drugs. So always have this in mind and take into account the mnemonic for the specific families that prolong the QT. So it would be A, B, C, D, and E. The A would be antiarrhythmics. Here we have class 1A and class 3. My mnemonic for class 1A would be a double quarter pounder. So DPQ, disopyramide, procainamide, and quinidine. Please let me know if I get something incorrect because we're here to learn and grow. Remember, fail often, fail forward. But yeah, just keep at it. The second one is, well, in class 3, antiarrhythmics are the potassium blocking agents. Then we have, of the class 3, almost all of them prolong the QT with the exception of amiodarone, because amiodarone actually is somewhat protective, and yeah, there's some ongoing debate, but it's more positive than negative. So antibiotics, the macrolides, prolong the QT. Antipsychotics, mainly the typical antipsychotics. Antidepressants, mainly the older generation ones. But even the SSRIs can prolong the QT, so always be wary of them. And the antiemetics, the citrons or these 5-HT1A antagonists prolong the QT, and these medications are seen more and more in chemotherapy because they're excellent for nausea in this context. So have these into account. Take these into account. A, B, C, D, and E. So now that we know why QT prolongation is important, now that we know what can cause QT prolongation, we should be able to identify the QT and to measure the QT. So in this diagram, which is the QT interval? Okay, great. The QT interval is this green box. Now that we have identified it, let's see from where to where it goes. So what isn't that difficult is to be able to draw a line of where the Q starts. So here we have the Q starting off, but what usually, or when we have a challenging electrocardiogram, what usually might get difficult is determining where the T wave finishes. So in this one, it's probably not that hard. In this one, it's a little harder than the first example, and this third one might get challenging. If this line weren't here, I'm sure many of us could have drawn the line right here. So that's why it's important that we review a little. There's some major points to know. There's not many, but look at this. This is something interesting. So if you see the first example, it's sort of counterintuitive that you have to draw this red line. What does this red line stand for? It's the tangent line to the T wave. So what is a tangent? A tangent is a line that is touching another line in just one point. So that's what a tangent means. And let's assume this is the T wave, and this would be the tangent going over the T wave and along it. So where should we draw the tangent to the T wave? We should draw it where it's the steepest. Where is it the steepest? Look at this. If you were on a car going down a street, you would like the street not to be that steep. So that's not a good example. So let's use another example. If you were going down a street on your car in neutral, without any gear on, just neutral, which slope would you choose? Would you choose this slope, or would you choose this slope? See the red line? Okay, you would probably choose this slope if you want to go down fast. Your objective is to become the world record of going down the slope. So you would probably choose this slope over this one. So where do you have to draw the tangent? Where it is the steepest. You're going for the world record. So this is the tangent and where it should be drawn. Why do I have to draw the tangent if I could just see where the T wave finishes and just draw a vertical line right there? Because things might get difficult. So in this case, you probably won't need that. Not in this case. Maybe in this case. But we'll see more challenging EKGs. So the more difficult it gets, the more output from the tangent line of the T wave. So have that in mind. And what else do we have to look at? Look at this discontinuous line. What is this discontinuous line? Here we have the explanation. It's the isoelectric line of the heart. And how is that manifested in an EKG? In general, it is the TP segment. But when there's tachycardia, you might not be able to see the TP segment, and you'll use the PR segment. So you'll draw a line through the isoelectric line of the heart, and where that line crosses to the tangent, to the red line, that is, you draw a point right there. And where will you measure the distance? You'll measure the distance from that point to the green, to where it crosses the green line, of course, in a straight line. That will give you the length of the QT interval. So let's see what else we have here. Here we have some little boxes. And what does this small box stand for? How long is this small box? Okay, pause the video and let me know how much does it take to get from here to here. So probably you were thinking it was 40 milliseconds or 0.04 seconds, and that would be probably correct, but there was a trap. This EKG is going much faster than it should have. It's going at 50 millimeters per second. The usual velocity for the EKG should be standardized EKG, and the one we have all our mental recognition patterns activated for is the velocity of 25 millimeters per second. So why could this be 50? Maybe someone pressed a button and it just its configuration went crazy. So always be ready to look at the EKG and see that it's the patient's EKG, that it has the patient's name. If you see an EKG that is on top of a table, be sure that EKG is for this patient and not for that other patient. Be sure to look all around the EKG. Try to look around everything and make your own interpretation of the EKG in conjunction with the clinical correlate of the patient, and after that go and compare what you're seeing with what the analysis EKG software analysis is saying. So don't do it the other way around, because number one, you won't learn as much. Number two, you might trust a computer software before using clinical skills. So what is the normal QT in general? The normal QT, corrected QT, is less than 450 in males or 470 in females, but there's different data on this, and there's other articles that might say 470 in males, 480 in females. What we need to know is that women usually have, after adolescence, and this is thought to be due to the role of estrogen, usually have a longer QT than males. So bear that in mind, and also take into account that above 450, better start thinking, and above 500, you don't have to think much. It's always prolonged. The QTC more than 500 is always prolonged. So how much does this QT measure? Give me a wild guess. Yeah, of course. So it measures 360 milliseconds. So the next question is Is the QT duration normal, abnormal, or I don't know? Which one would you choose? Great. The answer is I don't know. Why don't you know? Because this QT interval isn't corrected and we can't do anything. We cannot interpret a QT interval that is not corrected. The QT interval is dependent on heart rate. The QT interval is variable and changes with heart rate. So that's why we have to correct it. And with what do we correct it? We have different formulas to correct it. The most renowned one is the Bassett's formula. It has a lot of criticism, but at the end of the day, the one that is most used, the one that keeps on being the most used, the one that has the most evidence and more than 60% of the data on is the Bassett's formula. So for now, if the heart rate is between 60 and 100, try using the Bassett's formula. If the heart rate is different, try using any of the other formulas you feel comfortable with. So read about them and choose one and know why you chose this one. So I usually use Bassett. If I have tachycardia, I use Friederica. If I have bradycardia, I sometimes change among the different formulas. So remember that the QT needs the little c right next to it, which is the corrected QTC. So the world ain't all sunshine and rainbows, as Rocky said. Doesn't all EKGs don't look this neat? Many EKGs will look like this. And for these more challenging EKGs, just remember the basics. Use pattern recognition. So if I would start off telling you, measure the QT interval in lead D2 right here, might be a hard time. You might ask yourself, is this the QRS? I guess this is the T wave, but is this a P or is this still part of the T wave? So it would be complicated, right? So what I would recommend you doing is use your pattern recognition and tell me which one of all the leads is the one that looks the most similar to a normal EKG. Okay? That's it. It's V4 or V5, but V4 even looks even more normal. So if you can detect where the Q is and where the T is, you can answer the question. Why? Because remember that this temporally or in time, this part is the same as this part is the same as this part. So if you draw a vertical line down where you can effectively see the termination of the T wave, and you draw another line where you see the start of the Q wave, you can take that down and detect where the D2 is and then extrapolate this to the other leads and determine what the QTC is. So things may get very ugly here, and you can see that here we have two slopes for the T wave. So we have a not biphasic, because I guess biphasic would be up and down, but we have a bifid. We have a bifid T wave, and my question here is, where would you draw the tangent? See, this is an option where you should actually draw the tangent, because you don't see this crossing the isoelectric line no time soon, right? So here is where the tangent would be worthy of. So would you draw the tangent right here, or would you draw the tangent right there? So this is the specific reason I mentioned that the HRS got the example wrong, because this video is the one they are referencing of how to measure the QT. And as you can see right here, let's see it again. Look at where they are measuring drawing the line on the T wave. So they are basically stating that the T wave finishes right here. That is incorrect, because this is a technical consideration, which is that If the second slope is more than or equal to 50% of the first slope, you have to take it into account. So take it into account means that the tangent line should have been drawn right over here. So that's an important aspect, interesting aspect. Even the best of us can fail, so don't be too stressed out and just practice again. So we also have to remember that even the patients that have long QT syndrome, the accuracy of the EKG of detecting the long QT won't be perfect. It's 67%. What does this mean? You have to try looking for the long QT time and time again. You can't just conform with one EKG 1 year ago. You have to repeat it and repeat it, and the more you repeat it, the better. We understand that sometimes it's impossible to have an EKG maybe each 3 weeks or each, I don't know, depending on the clinical context of the patient. But have a high index of suspicion. Try to look for it when clinically indicated, not when we just have a patient that's coming in for foot pain and no special indication for an EKG. If you have this same patient with foot pain and you ask the patient, do you have any family history? Yeah, I've had my father died at 35. We don't know why. My aunt on my father's side died at 42. Why? Not sure. Okay, get an EKG. So if we don't have time, we can use the rule of thumb. Something which was very interesting today while I gave this lecture was that I didn't know that I was actually using a paper published by emergency medicine physicians from this center. So that was very interesting. So I guess two of the authors for this article are based in this center. So that's great news. That's incredible, a great coincidence. And it's very nice to know that I'm presenting on something, and coincidentally, it's the people who made this are actually from here. So if you have a heart rate between 60 and 100, or a normal heart rate, you can use half the RR interval. So just look at the RR interval, and if the QT is half the RR or less, probably normal. If the patient is in bradycardia, go and measure it, of course. But that's a fast assessment when you have a patient on vasopressors and you have to titrate them. You have to do a bedside ultrasound. You have to talk with the family. You have to put in the orders. So in those cases, you probably won't have the time to analyze each part of the EKG thoroughly. So let's use, when we measure it, measure it accurately. Let's try to use our formulas. We don't have to know them by heart. We can use any of our most trusted medical apps. We have to also assess the risk for the patient. So we can't do anything with just a number. Even though you have the corrected QT length or corrected QT duration, that doesn't mean much unless it's more than 500. If it's more than 500, patient definitely is high risk. But if it's between 450 and 500, try to go assess the risk. Even if the QT is normal and you have a strong family history, or you have congenital deafness, mutism, the risk might be higher. So take this into account. So remember that we don't see numbers, we see patients. So I'm using this scale, which is the Schwartz scale, which is used for diagnosing long QT syndrome, or long QT congenital, right, syndrome. That's what I'm mentioning right here. And this is to point out the importance of the clinical context of the patient. So the more points you give this patient, the more probability of diagnosing the patient with LQTS. So four or more, this is my mnemonic, four or more for sure. 2 to 3 could be 1 or less, let me guess. So probably not. So here we have in this scale the history of syncope, some major symptoms such as congenital deafness, and some other alterations of the EKG that would be worthy of another talk. But we have T-wave alternance, notched T-wave in 3 leads, bradycardia, etc. So just to demonstrate this point, this female has a QTC of 480 milliseconds and is asymptomatic. So her risk compared to this male patient is lower, even though her QT is longer than his. He has a 440 milliseconds corrected QT, but he's also had history of syncope and QT alternance in previous EKGs. So take into account the clinical context. And the treatment, well, in general, when you have a long QT, first treat any underlying causes. So be sure to check electrolytes. Be sure to check medications. Don't over-medicate the patient if unnecessary. And after you correct all the correctable causes or the modifiable risk factors, a diagnosis of exclusion could be long QT syndrome. So if you actually corrected for everything and the patient keeps on having a long QT, you might have to resort to beta blockers, which are great in every step of the pyramid. If the patient is higher risk, you might have to go to the ICD or implantable cardiac defibrillator. This is the scenario where these devices have shown the most cost effectiveness, because this is basically it's a patient that is dying secondary to an arrhythmic event, and this is one of the main uses for the ICDs. So we have other cardiomyopathies such as for example, in the context of ischemic cardiomyopathy, sometimes the patient dies due to heart failure and not to arrhythmia. In this case, probably this is a great idea if you have one of these patients. So yeah, if the patient has multiple shocks and isn't responding very well to the ICD, you can consider this other option, which is a left cardiac sympathetic denervation, but that's too advanced and your cardiologist will be in charge of taking care of that. So 9 take-home messages. So here you have the different messages, but in general, the EKGs are inexpensive and easily attainable. The monitor does not replace a 12-lead EKG. A normal physical and a normal lab work and imaging does not rule out prolonged QT. Don't forget to get the EKG if you have suspicion. Watch out for medications and electrolytes. The QT is dynamic, so you also have to be dynamic with it. And if the cardiologist always asks you what is the story of the patient after he sees the electrocardiogram, you should also take into account the clinical context, because it's important. Do not fear the language of the heart, so measure the QT several times and compare. And if in doubt, ask. And if you want to have a great time, in doubt, ask 2 electrophysiologists for help. Sit back and enjoy the ride, because you'll get a whole lot of data and you'll ask yourself, what did I study again? Do I actually know something of electrocardiography? I'm doubting the P wave. So that's it for today. Thank you very much, and hope this helped you.